Brittany, can you turn on your microphone? Okay. That's great. Can you hear us? Anuja, can you turn your microphone on?
Got it.
Okay, great. Everybody's live on, and thank you very much. We have had technical difficulty with Angelica Rodriguez from Brazil. She was on, but her connection was unstable. So she was to present the first case, which now we will delay, and we might go directly. But who's presenting?
Yeah, the second case would be Clinica. Barretos. Dr. Georgia from Barretos.
The third case. Is she on? Is she on?
She's on.
Okay. So, Akna, it's between you and Dr. Sintra from Barretos as to who goes first with the first case, if you don't mind. We're going to start with one of you two. Akna, would you like to go first? Akna,
sorry.
Can you hear me? Where's Akna?
She's here. Akna, can you hear us?
Are you asking me?
Yes.
I can hear you perfectly.
Akna, can you start the presentation with your case, please?
That's Barretos talking. Akna and Mauricio, can you hear us? I think their connection might be frozen.
Yeah,
so,
they're frozen.
Yeah, let's move on to Dr. Georgia.
So, Dr. Georgia, if we could have you present, that's the third case, the last case of the three cases today from Barretos. Can you hear us, Doctor?
Yes, I can hear you perfectly.
Thank you. So we're going to ask you to start the presentation, Dr. Sintra. Thank you very much. So can I please just say good morning to everybody, to our live Gynecologic Tumor Board, and a special thanks to doctors presenting our cases if we all get connected. Dr. Angelica Nogueira from Minas Gerais in Brazil, Dr. Georgia Sintra from Barretos Cancer Hospital in Brazil, and Dr. Mauricio Bessa and Akna Calabrese from Clinica OMR in Salvador, Brazil. Because of technical issues, we're going to start with Dr. Georgia Sintra presenting the first case, which appears in the PowerPoint slide deck as the third case. I'd also like to welcome the panelists, including myself, Dr. Paul Gast, Dr. Marcelo Del Carmen, Dr. Tom Randall, Dr. Don Dizon, Dr. Alexandra Rauhan, Dr. Mike Vera, Brittany Bishovsky from Dana-Farber, Kathleen Schmeller and Dr. Anuja Jingran from MD Anderson, and Linus Chang from Mount Sinai Hospital in New York City. Thank you very much, everybody, for joining. Please keep your microphones on mute unless you are speaking. Just keep them on mute so we can all hear the presenting case and the discussion, please. And with that, I'd like to, with that introduction, let's get started. Please, Dr. Sintra, if you can hear us, can you begin your case, please?
Okay. Thank you again for the opportunity to present this case. So our patient is a 32-year-old woman. Is everyone hearing me? Is it okay?
Yeah. Yes, sir.
Her complaint is of postcoital bleeding for the last 3 months, and the last pap smear was 4 years ago. She's nulliparous, and she has a very, very strong desire to preserve fertility. She's recently married, and she was referred to us, especially because we are one of the few centers that do trachelectomy here in Brazil, and she wanted to preserve fertility really bad. On her physical exam, she has a PS of 0, her BMI 24, and on the speculum exam, 2 centimeters exophytic lesion on the cervix with no vaginal or parameter infiltration, and the biopsy a grade 2 in the cervical adenocarcinoma. Okay, next. So this is her MRI. It showed actually a larger lesion. It's basically in the cervical lesion, and in the largest diameter, it measured 3.4 centimeters, but it didn't have any vaginal or parameter infiltration. And on her CTs, upper abdominal and thorax CT, there was no signs of other disease, of lymphadenopathy or chest metastasis. Okay, next. So she is a stage 1B1 cervical cancer with a very strong desire to preserve fertility. So the two options we thought to offer her was to go straight to radical trachelectomy with pelvic lymphadenectomy, or because of the size of her tumor, it's a 3.4 centimeter tumor, we considered doing neoadjuvant chemotherapy followed by surgery. We discussed this with the patient, and next, please, Jessica. And we decided together to do sentinel lymph node dissection with systematic lymphadenectomy and radical trachelectomy. Okay, next. On her pathology report, it showed an endocervical adenocarcinoma. The MRI was strictly correct. It was a 3.4 centimeters lesion with a superficial stromal invasion, only the upper third, but with positive lymphovascular space invasion and a lymphatic embolus on the left parametrium. Only embolus. It's not a continuous spread of the tumor to the parametrium margins, and no lymph node involvement, but they found isolated tumor cells on the left sentinel lymph node. So I did a short video of one of our cases of trachelectomy. Jessica, can you? It's not this patient's case. Actually, the surgery of this patient was much harder because of the tumor size. We couldn't use a manipulator or things, but I just did a small video, edited video to show how the participants are approached for trachelectomy, for radical trachelectomy, since here in Latin America it's not a very common procedure to perform.
Just give us 1 second.
Just a moment. I have to download the file.
We're just downloading the file to play the video, so just give us a second, please.
Okay. If you want to discuss the case, and I can show the video after. I don't know which while you're downloading it.
Can I ask a question? Do you do it obviously laparoscopically, laparoscopic
yes.
radical trachelectomy? And knowing this is a larger tumor, so you discuss with the patient about the options and knowing the risk of, it's pretty high with a tumor that is larger, between 2 and 4 centimeters. This almost like 75% of a patient may need adjuvant therapies, and with the radical trachelectomy. So, what was the process of pre-surgery discussions among your group? And
yeah, we brought the case to our multidisciplinary discussion, but the patient is very, very rigid about the idea of preserving fertility. She was actually she saw like 4 doctors, other institutions before she was referred to us, and she came to us with a strict idea of doing this specific surgery. She had read a lot about it. She's a very instructed patient, and we discussed this possibility with her, with the risks of having the Salins criteria and the need to do adjuvant therapy. And we offered her the neoadjuvant chemotherapy, but with the risk of having ovarian failure due to chemotherapy, and the patient did not have any financial main means to do to froze her eggs or anything like that. She chose to do the surgery up front. But we discussed it very, very largely with the patient and between our group. But in this specific case, the patient didn't change her mind. She was very rigid about the idea of doing surgery.
I was in your hospital last year, was really impressed. I think Barriatos is one of our most amazing hospital I have gone to. The service you provide, the surgical ability you have. What is your experience at your hospital for this 1B1 between 2 and 4 centimeter tumor size in your radical trachelectomies in the past that you have?
Well, One of our doctors, you met him, Dr. Marcelo Vieira. He's the one who's doing most of the trachelectomy cases, and he's becoming a little bit famous here in Brazil. So a lot of patients from everywhere in Brazil are being referred to him. And well, in the last 3 months, we had this case and another one with a tumor larger than 2 centimeters. We always discuss with the patient, we say it's not the proper indication. The proper indication would be a tumor with less than 2 centimeters. We always analyze the images on the MRI to see if we can prevent, to see the stromal invasion and other Sadler's criteria that we can be presented, we can prevent. But fortunately, the last patient, not this one that I'm presenting, she had a really exophytic lesion. It was more than 3 centimeters, but it was basically exophytic, so she didn't have any other criteria for adjuvant therapy. It was only these 2 cases that we have on the last 3 months that it's larger than 2 centimeters, so we don't have a follow-up to say how the outcomes are coming. And the other patients, we have so far 16 trachelectomy patients in the last 2 years. We had only 1 recurrence, which was an adenocarcinoma, but it was less than 2 centimeters. These 2 cases that are larger than 2 centimeters, the follow-up's too short. They were operated the last 3 months, so I can reply to that, Dr. Chen.
Dr. Sintra, can we get to your question about chemotherapy and fertility preservation? Because I've heard some mumblings in the room here in Boston, and I'd like to hear maybe Don Dizon would say, you were concerned about the risk of losing fertility in a 32-year-old woman by giving chemotherapy. So can we have a discussion on that?
Yeah, in Brazil, the fertility centers, they're very, very expensive. Most patients, they don't have access to them, especially our patients here in Barretos, that's basically public health system. And they're very concerned about the losing fertility after chemotherapy. It's very interesting.
Well, I think, the issue, hopefully you guys can hear me, I think the issue is it's not so much that all chemotherapeutic agents are going to cause infertility. I think that would be incorrect. Most of our infertility data actually comes from breast oncology when we were using anthracyclines, which are not used in cervical cancer. So I think actually you could have counseled her for neoadjuvant chemotherapy with very, very little risk to future fertility if we use a platinum and a Taxol. Certainly, there's not a large series about pregnancies after taxane therapy, but it is absolutely possible, and I think the risk for future infertility with platinum Taxol is actually quite low. So I think there is this concept which is incorrect, that all chemotherapy will affect the ovaries the same. That is not true, and actually her age actually predicts she would have return of ovarian function at an early age in her 30s. So I probably would have not pursued trachelectomy up front. I would have offered her chemotherapy with hope that she could preserve her fertility. But at this point, I think Linus is correct. Even with a trachelectomy of a larger lesion, I would be uncomfortable without offering her some form of adjuvant treatment. And if you use radiation, she will not be able to carry a child.
Well, I mean, you can. One of the things is that you can always PEX the ovaries, try to move them away from the radiation field, and hope for the best. The thing with if you PEX the ovaries and you move them away is that, like you said, probably that patient will require some kind of fertility help to get pregnant.
So, there's a lot of, this is a little scary for me because I think if she was at MD, in the United States, if we were going to do a trachelectomy, she probably would have gotten neoadjuvant chemotherapy. So now she has a couple of risk factors that are a little bit nervous, that make me nervous, the lymphovascular space invasion and then the thing in the perimetrium. But, the Japanese and the Koreans tend to treat these patients with chemotherapy and don't have radiation afterwards. I don't know. What do you guys think?
Yeah, actually, Dr. Wolf, who is now in Brazil, that's what he does. adjuvant chemotherapy afterwards, and he has some success. But I think the current trend is, like you said, neoadjuvant chemotherapy followed by radical tracheolectomy. And this patient concerned me with our ITC there and all those risk factors. And would the group think of recommending adjuvant chemotherapy for this woman, or should she have more aggressive like chemoradiation and follow-up hysterectomy? Because earlier you brought up a point about moving the ovary away and then radiate. That wouldn't really help her fertility, right? And after radiation, she's not going to be able to conceive at all. It'll be a surrogacy, if anything.
Yeah.
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 I think we need to, I think everybody is aware, but we need to just bear in mind that we're working on very limited evidence here, right, for all of this. So I think it's instinct, and I think it sounds to me like the team at Barrettos gave her a pretty clear plan, which the patient had very set ideas about what she wanted, and ultimately they complied with her very specific requests. And you know, she'd been counseled on the risks. Unfortunately, she has those risks now. Based on the limited evidence, are we comfortable with
chemotherapy alone?
Adjuvant chemotherapy rather than adjuvant radiotherapy? I guess you know, we'd have to present to her that we're working on very, very limited evidence here.
Well, I mean, the evidence, Tom, it's actually there is a randomized trial that was presented, right? I mean, we could fall back on Peters, the Peters data, and she has, if you call the ITCs a node positive, which is a stretch. Certainly in breast oncology, we don't consider ITCs node positive, we consider it node negative. But in this case, Peters' criteria applies, and that used chemotherapy plus radiation therapy after hysterectomy. She hasn't even had a hysterectomy, she had a tracheolectomy. My point, I guess, is going forward is the part that we could have counseled her better at is that not all chemotherapy affects the ovaries the same. I actually don't think we would have risked her fertility had you given her neoadjuvant platinum taxanes. And I think that's an important point. It's not like an anthracycline or other agents of that group, which appear to have a far more significant impact on ovarian function in young women.
So
I think that telling you to do chemoradiation, actually, and you can PEX her ovaries. She will not be able to carry a child. She can still have a genetic child using a surrogate. But if you are actually going to try to cure this woman, then we need to think about that first, and try to do that as well. I mean, there's no sense in her becoming a mother and then leaving an orphan child. We did the surgery to try to cure her. I don't think any of us feel comfortable that she's been cured now with surgery alone.
Yeah, I agree. Oncologic outcomes should always be first in our mind than anything else.
Yeah, but remember, Don, as you very clearly said, it's an extrapolation to use the Peters data in this case, because we don't in fact have a positive node, right? We have
But Tom said this criteria she would fit in, right? 2 out of 3. Well, not 2 out of 3, actually 1 out of 3.
Yeah, right. She only has 1 out of 3.
So
I don't know. We work.
Can I ask a question? I'm not obviously a gynecologist. Adjuvant now after surgery, adjuvant therapy, which was one of the questions, and you've already said, Tom, that there's a paucity of data for both chemotherapy and radiation.
Yeah.
And I thought I could say
there's a paucity in scenario where she's had just a tracheolectomy.
Yeah.
That's the paucity.
Right. Right. So can we just have a weigh in on opinions about whether chemotherapy or radiation or both is the necessary option here, the best option for an oncologic outcome? Which is the best?
I think if we think that the node is positive based on Peter's criteria, I think chemo-rats is the best option for her. If you don't think that's what I would feel comfortable offering her.
Yeah, and I mean that's a standard in the United States, but I do think, you know, so that would be our standard. The question is it the standard everywhere else? And that's what I was just saying. In Japan, that would not be the standard. The standard in Japan would be chemo. But the standard and probably the safest for us in the United States would be chemo RT at this present time.
Right. Thank you.
And Anuja, I'm sorry, I know sort of only vaguely about that literature in Asia. Do they have clinical trial data as robust as the Peters data to recommend that?
Yeah, but you know, that's also after a radical hysterectomy, and they do extensive radical hysterectomy. So, you know, as Don says, this patient really hasn't had a radical hysterectomy, she's had a trachelectomy. So, but they do have pretty robust data for chemotherapy. But, you know, have they published the data? I haven't seen it, but that's how they treat it. But it is after radical hysterectomy.
Right.
Their radical hysterectomy is real radical hysterectomy.
It's ultra radical. It's close to a type 4 by Anderson standards.
Right. So I mean that would be the standard here. I think that's what we would tell her. And then if she wants, I mean, the minimum I would do is I would give her chemo. I mean, she at least has to have chemo, I think. Don?
I agree. I mean, you know, I think Alejandro summarized it best. I mean, you know, in the U.S. she would be offered chemo radiation, and I completely understand the fertility issue here. But I think part of our job as oncologists is to reframe it as we want to save your life so you can someday become a mother, not to compromise her care so that she can carry a pregnancy with the risk that she could die of cervical cancer later.
Right, the patient first. Can we move on, please? And we're still having trouble with connecting with.
I think they are both
we were,
here. So
okay, so go ahead.
Were we able to watch the movie? She wanted to
Angelica, I think you're
There was
next.
an
If you could
issue
do your
with the
first case, that
file,
would be great.
So I couldn't download it, unfortunately. Sorry, Georgia.
Sorry, Georgia.
Video,
Can you show us the video again at another meeting, please?
Of course.
But we just
Can I ask one really quick question? I'm sorry. I had just one really quick question to Dr. Dong. I'm sorry. If we, of course, what we conclude is that the best option for the patient would be neoadjuvant chemo. Would he consider doing GnRH analog for this patient? No, extrapolating from breast.
I would, and I've done that in the past here. Actually, I have given a GnRH analog while giving chemotherapy, with the hope that it will help, you know, preserve ovarian function based on the one trial done in breast cancer. But yes, I would.
Okay, thank you.
Angelica, thank you very much for the case. Angelica, could you go next, please?
Yes, thank you for the opportunity. I'm just waiting for the slides.
Right. There we have Angelica and the case. Thank you. Go ahead, Angelica.
No, I can see the case.
Oh, no? Just a second.
I can see Georgia.
Just hang on a second, please.
Just a moment.
Just 1 second.
Can you see us on your screen right now?
No.
No. Okay, just a second.
No problem.
Can you see us now?
No.
Do you see the slide?
No.
Can anyone else see the slides? Any of our other participants online, can you see the slide on the screen now?
Yes.
Yes. Here, yes.
Can she read
Angelica, if you have a copy of the slides in front of you, can you read them?
Yes, I can use my slides. Just one
Okay.
minute.
Just say next slide and we'll advance here. Thank you. So if you'd like to start with the first slide, Angelica.
Okay, so thank you for the opportunity to present. This is a 64-year-old lady, one daughter, was previously healthy, HIV negative, non-smoker. At the beginning of 2015, the patient presented with pelvic pain, and at that moment, her CA-125 was 320. The patient had been submitted to a colonoscopy in 2013, and when she had this pelvic pain, she also had an endoscopy, and it was normal. So last year, she, at the beginning of the case, a pelvic CT, which showed a complex pelvic mass, and the patient did not have metastasis on the thorax or in the abdomen. The patient was submitted to a tumor biopsy, which showed a mucinous adenocarcinoma, and this is her immunohistochemistry, which was negative for cytokeratin 20 and also negative for CBX2, and the profile was ovarian cancer. The patient was treated in another institution, and the mass was considered unresectable at that time, and the patient began last year dose-dense chemotherapy, dose-dense paclitaxel combined with carboplatin, and the patient received 6 cycles of chemotherapy. At the end of last year, her CA-125 was 103, and the patient was at that moment submitted to a panhysterectomy, and the surgeon told that there was residual macroscopic in the peritoneum. This is the pathology report. There was serous low-grade carcinoma involving ovaries and fallopian tube, and glioma involving the ovaries. The patient started on chemotherapy again, the same chemotherapy. She's now on paclitaxel, dose-dense, and carboplatin, and she has been now submitted to 2 additional chemotherapy cycles. And now she came for me for a second opinion, and I bring the case for your opinion. The patient is now ECOG PS1, and I asked pathology review, and I asked thoracic, abdominal, and pelvic CT. Now I just have the report of this. The patient has peritoneal disease, and she doesn't have other signs of metastasis. And this is the second opinion for the pathology review. According to the immunohistochemistry, the patient, the tumor has estrogen receptor positivity, and the tumor again is negative for cytokeratin 20, and in the PI67 is about 10%. The review concluded for serous low-grade adenocarcinoma, no mucinous carcinoma, no mesothelioma, and the pathology reported that the patient presented partial response, almost complete response in the omentum, but the patient presented only minimal response in the ovaries and fallopian. So I have your opinion. What's the optimal management of this patient with low-grade serous adenocarcinoma, ER positive, partially responsive to chemotherapy with residual disease in peritoneum after surgery? Thank you very much.
So who wants to take a stab at it? Who wants to start? Dr. Chan, would you like to speak about this case?
I think he's had to.
Oh, he's had to leave. Okay.
And Don as well.
And Don has left. Okay.
Don, look at Don's chair.
Anybody? What is your opinion about serous low-grade adenocarcinoma?
So the first question that I have is that, so on biopsy was a mucinous, and then final pathology was a low-grade serous. Is that correct?
Yes.
Okay. And then, so she got 6 cycles of presumably neoadjuvant chemotherapy, and then had a hysterectomy, and then 2 more cycles afterwards.
Yes,
Okay.
8 cycles to this moment.
Got it. So I think the issue with serous low-grade adenocarcinomas is that we know that they don't respond very well to chemotherapy. They're very slow-growing tumors, but there is good evidence, and I think the biggest series is from MD Anderson actually, and we know that they just, very few of them actually will respond to the current chemotherapy that we have, the standard chemotherapy of carboplatin and Taxol. So I think, we still give them this chemotherapy to these patients because we don't have anything else to offer them. But I think there are currently some trials looking at target therapies, some molecular pathways that we think that we can target. But at this point, I think this case has been managed properly. I mean, that would be the standard chemotherapy approach. I think, the 6 cycles of neoadjuvant chemotherapy, it's a little bit kind of not what we would have done. I think most people would give 3 or 4 cycles of neoadjuvant chemotherapy and then interval debulking and then 3 more cycles maybe afterwards. But again, I don't think there's anything else that we know that we will work for this patient except here we would offer her a clinical trial looking for targeted therapy.
Can you be more specific and mention one maybe?
I think right now we're using like the MAPK pathway. I think that's one Mark Beers has opened. I don't know.
Good.
But I think different institutions are trying different targeted therapies.
Because of the unsuccessful
Exactly.
nature of standard chemo, right? Mm-hmm. Anybody else with an opinion, Tom?
Well, I think it's an interesting question. I don't know the answer of, based on the predicted and observed chemo resistance of this tumor, would you, Ali, recommend continued chemo after this point, from after those additional 2 cycles, or just follow her closely?
Just follow her closely.
Yeah, I agree. I would make an argument that given the chemo resistance and the amount of therapy she's had to this point, I would just follow her closely and treat her recurrence.
Yeah.
And how about tamoxifen or anastrozole?
That's a great idea.
That's a great point, and I think tamoxifen is, there is some data, retrospective data, that these tumors actually do respond to hormonal treatment, and I've used tamoxifen in some patients in these situations, and it does. It's hard to know if it really is working or it's just the fact that these tumors grow very slowly. But I don't think it's unreasonable to offer her.
So it's not possible to do there's no clinical trial data about tamoxifen?
No, there's retrospective data that these tumors do
because
respond.
you know that aromatase inhibitors replace tamoxifen in breast cancer, more or less.
People have used tamoxifen, people have used anastrozole.
Right. The only thing about tamoxifen, I'm just thinking about a woman with a pelvic mass. Tamoxifen's one side effect is hypercoagulability and thromboembolism. So it's a partial contraindication to tamoxifen. Maybe somebody should do aromatase inhibitors, or are there just not enough cases to do?
I think most of it is just retrospective small case series.
Right. Would there be interest in that? Not really.
Yeah, I mean, I think with low-grade cirrhosis that it's a very uncommon scenario. It's like 5% of all ovarian cancers.
I see.
So I don't think there's enough cases to really
make a really powerful clinical trial.
Yeah.
Yeah.
But it's an interesting, definitely. I think hormonal treatment is definitely an option for her.
Well, I mean, in some cases, endocrine therapies have had to be introduced without clinical trial evidence, like aromatase inhibitors in males with breast cancer. It's too rare to do a clinical trial. There are some scenarios in oncology where you just can't do a clinical trial.
Exactly.
And this may be one of them. Okay, well, thank you very much. Thank you, Angelica. That was a great case. Can you still hear us, Aknar from Salvador? Aknar? Salvador, can you hear us?
Yeah, I can hear you, but we...
Yes, thank you. Can you present the first case, please? You or Dr. Bessa?
Okay, yeah.
Please go ahead when we share the slide.
I'm waiting for the slides, yes.
Right. Okay. Go down. Okay, we're ready, Aknar. Either of you can present the case, please.
Click on me, it's a 52 years old woman. She complained with pain, with urinary symptoms, and then she go to her gynecologist. Her last pap smear was more than 2 years ago. when she went there, her gynecologist found next slide, please. Uterine mass, and then performed the MRI and show. I can't read. It's too small.
Do you want me to read it out? Can I read it out?
Yes, please.
And showed an expansive lesion compromising the circumferentially around the cervix and a right parametrial invasion and contact with the adjacent mesorectal fascia. The lesion extended inferiorly to the proximal region of the vagina, infiltrated the uppermost portion of the rectovaginal space. Hepatic steatosis was found, leiomyomas in the uterus, and simple renal cysts, and that was what the MRI showed.
Yes. Then she performed a cervical biopsy that shows a moderately differentiated squamous-cellular carcinoma, and then she went.
Is that a Brazilian term or is it a real pathology? What's the pathology in English?
I think that's a squamous cell.
Squamous cell carcinoma. All right.
Carcinoma.
Okay, continue, please.
So we did a PET-CT because it was a clinical stage 2B, and on PET-CT there is only this mass on the surface, but there is no lymph nodes involvement. And that's the next question, please. Next slide, yes. So with a negative PET-CT, is there a role? And we know there are some ongoing trials.
Just repeat, please.
About chemotherapy.
So we've got we can't hear you properly, so can we just all read the questions on the board? The first question is a surgical lymphadenectomy with a PET-CT being negative. The second question is what is the role of chemoradiation, or radiotherapy, should I say? And the third question is...
The second question is cisplatin still the best chemotherapy to combine with radiotherapy? And the third question, if we know that there are some ongoing trials on adjuvant chemotherapy, but in this case, would you consider to do adjuvant chemotherapy after chemoradiation?
We've lost Dr. Chung, so and Don, so what did you?
I think Don is around. So I can take. I think for
yeah,
I can try to answer the first one. What we have done here at Boston, I think if we have a negative PET-CT, I don't think we would recommend a surgical lymphadenectomy here. Even though PET-CTs are definitely not 100% sensitive, they are pretty close, and I think it's more than 80%. So if we have a negative PET-CT, we wouldn't do a lymphadenectomy. If there's any concern, we would think about doing a biopsy of if there's a hot spot on the PET-CT, but with a negative PET-CT, I think I will feel comfortable not doing a surgical lymphadenectomy.
And then the next question about chemotherapy.
I think the data that we have currently is, like you said, cisplatin or radiotherapy. I think there's more and more data coming out about maybe combining with other chemotherapy agents, but the best evidence that we have as of now is cisplatin radiotherapy. I think the good question would be whether you would be doing outback chemotherapy, and I think that's something that maybe Don can comment on, but I would probably think about it. I mean, this looks like to be a pretty nasty big tumor.
Don, would you like to say something? Your microphone is on. Yeah, that's
sure. I think Alejandro's right. I mean, the standard is still to do just chemoradiation if necessary. The data, as I'm sure you're aware, because it came from Latin America, was the Mexican trial from Duenas Gonzalez, which used cisplatin and gemcitabine with radiation, followed by I think it was 3 cycles, Tom, of cis and gem after. sort of outback chemo showing a survival advantage to adjuvant chemotherapy. When we use it here, it's on a case-by-case basis, and it depends on how worried we are that she could have a recurrence based on pathologic features. And I don't think I can sit down, and Alejandra and I probably have different ideas of what that might look like in terms of high risk, but node positivity, large tumor, LVSI, parametrial involvement, basically the Peters criteria being positive. All of those things would factor into that. We don't use cis and gem with radiation therapy here. We still just use cisplatin and radiation. And then we would follow it with carboplatin and Taxol. That's the Outback trial that's going on right now, is to use a platinum taxane adjuvant backbone after chemo RT. I think it's accruing well internationally after a very large lag. But the only data to suggest adjuvant chemotherapy plays a role came out of Latin America.
Yeah. I completely agree with Don. I mean, the other option of chemotherapy would be that there's actually good randomized data, cisplatin and 5FU, and sometimes when we are worried about it, when we have like someone who's at high risk based, like, I mean, this patient I would be very worried about it, we can consider giving cisplatin and 5FU. It's a more toxic chemotherapy, and you have to admit patients, they have to be admitted for 5 or 6 days, and it's more troublesome, but that's something just to consider in this scenario.
Yeah, and if you do that, then and just to reiterate that point, the data from the Peters trial showed that cis-FU RT is better than RT alone. We've not had any randomized trials comparing cisplatin RT versus cisplatin 5FU RT. But when we talk about the Peters criteria, if you want to be completely consistent with the data, you would do exactly what Alejandro said, which is use cisplatin 5FU with RT. The reason we don't do it is a toxicity reason. It's very difficult to get in that second round of 5FU, even if you hospitalize patients. It's a very toxic regimen. I certainly would not.
High dose. It's like, I think they get like 1,000.
Okay.
Over 5
Yeah.
days.
Okay. But that's the reason, because
Yeah. If you did cis-FU RT, Alejandra, I would not give her adjuvant chemotherapy after that.
Yeah, that's. There's no.
I think that the what evidence we have also goes back to the question of whether to do the surgical lymphadenectomy in this case, and that is that we don't have enough evidence to say that the surgical lymphadenectomy would change her management after chemo and radiotherapy. I don't think there's compelling evidence that the surgical lymphadenectomy itself is therapeutic. I don't know that there's the only option would be if there was a possibility to somehow boost that site where a microscopically positive node might be identified. That could be argued to be potentially therapeutic, but I don't think it's been proven to be therapeutic.
We have a few minutes left over, so if I could just get your insights into sort of epidemiologically, one of the big issues with Latin America is late presentation of cervix cancer and other solid tumor malignancies. But I haven't yet been convinced that that's been true, that there's a real difference between ovarian cancer presentations in the United States and in Latin America. Is there anything that should be done to secondary screen for earlier detection, or have there any insights about the cases we've heard about from Latin America for ovary cancer versus cervix cancer?
I think here, the data in the United States still is that 80%, 75 to 80% of the patients with ovarian cancer will present with advanced stage, meaning more than stage 3 and above. So I don't think, and we haven't changed that in more than 40 years. There's I think the UK has been pushing whether to do screening with CA125 and ultrasounds, and they actually just published the last report on Lancet last month that they have a screening method that they do CA125s, right. And if there's a change in the trend of CA125, that triggers an ultrasound, and that was
It's a very old idea, right?
It's an old idea, but the trial was just published, and what is tricky about that study, and again, it was just recently published, is that when they look at the overall data, it didn't seem that screening had an impact on survival. Right. But when they divided whether patients were like the survival within the years 0 and 7, or versus 8 and 14, like it seemed that there was an impact on survival advantage if we were screened after 7 years.
Right.
But I don't think, ACOG or all the, I don't think here in the United States we're going to start doing screening for ovarian cancer.
So Angelica and Eduardo Polino are both joining us here in Boston in the summer, and we're planning on building a database for gynecology and cervix cancer neoadjuvant therapy outcomes, neoadjuvant chemotherapy. Is there anything about it interesting about ovarian cancer from a database point of view that we can tap better internationally than in the United States? Or is there sort of a burning need for any question to be answered that could be built into a database, or not really? Is this going to remain one of those rare but cryptic kind of cancers forever?
I think it will be very, I'm from Mexico, and I still don't know how ovarian cancer is treated down in Mexico. I think there's still, here we know we have a good evidence that either we give primary bulking or neoadjuvant chemotherapy, but I think different countries might treat it differently.
Okay.
So it might be interesting to look at
patterns of care.
Patterns of care. We've just done a very large Latin American survey in breast cancer of patterns of care, comparing them to international guidelines and North American and European and Canadian standards. But so that might be something interesting to do in ovarian cancer, perhaps.
I also think that another interesting thing about having a registry of ovarian cancer patients is that superficially ovarian cancer is considered a rich world disease, and I think that that's probably with better registry data will be found not to be the case.
Right.
And so I think data...
So is the incidence less common in Latin America at reported incidence?
So we don't know.
Well, I think we don't know, right? Okay. We don't have robust enough data. So I think to have better data about that, I think in rural areas of Latin America and in sub-Saharan Africa and South Asia, there's reported lower rates of ovarian cancer, but I think there are a lot of unreported cases in those settings. So I think to have better information about that, obviously we're not going to start a population-based cancer registry, but even to have patterns of care and
But
there are international guidelines for ovarian cancer management.
We have NCCN guidelines, and I don't know if other countries follow those same guidelines or not.
Do you follow, Angelica, do you follow NCCN guidelines for ovarian cancer management, or anybody on the line? ACNA or anybody?
Yes, the main institutions in Brazil, they follow NCCN, but I think that we could work on it. I think that that we have to have a standard and to teach Brazilian doctors to treat it well. I think that ovarian cancer is not very well treated in the country, and our main problem is access to surgery. I think that's the access to the basic drugs we do have. We don't have access to bevacizumab, for example, but to all other drugs we can have it in the public health system. But access to good surgery is really a huge problem in the country.
Are there a lot of rare histologies in ovarian cancer that make them into rare cancers? There's subtypes of rare cancers.
There are rare
pathologies.
But 80% of them are serous, that it's high-grade serous cancer.
Right, okay.
80%, I think. But I think it will be very interesting to see how people are treated outside of the United States, for sure.
And just for my interest, the type of ovarian cancer that BRCA1/2 carriers get is what?
It's usually, like BRCA is usually associated to serous.
High-grade serous, okay, the more common garden type.
I think one other thing that would be interesting, Angelica, to study with the cervical cancer patients, as best you're able to capture it, is any kind of history of what was happening to those patients prior to presentation. And I think there's a story to be told there. A lot of times, unfortunately, it's just trickier to tell, but a lot of times from what we're hearing from you guys is that they've been to smaller, less cancer-focused institutions and had variable treatment. And it might not be as popular with the Ministry of Health, but that's a story that it might be very well worth telling.
Well,
after the
in general, we find in our research that about 30 or 40% of women with abnormal results don't get follow-up at all. So therein lies a big problem. You know, they aren't seen despite an abnormal cytology or pathology, be it PAP or whatever. And that's something that can be addressed for sure to sort of clinically downstage patients. I think one of the features, everybody knows this, I'm singing to the choir, but one of the features about all solid tumor cancers in South America is that the mortality is so high, and it's predominantly, not entirely, I think what we do is important to kind of improve patterns of clinical practice, but the predominant reason is higher stage at presentation, you know, 3s and 4s. In breast cancer, it's a mirror image. The number of 1 and 2s in the US for breast cancer is very high, and 3s and 4s is very small, and it's precisely the mirror image in South America that mostly it's 3s and 4s with small number of 1s and 2s. And we've shown that in our various research papers, and Brittany might comment, but we have shown high clinical staging presentations by rural versus urban patients like in Mexico, specifically in breast cancer, and by publicly treated patients versus privately treated patients. So we see this demographic in the urban poor, the rural poor, the remote patient, many types of public patient. They all have to present with stage 3 and 4 disease, and a lot of it is because of failure to follow up on abnormal screening tests or whatever.
Yeah.
Okay, well, that was a very good conversation and a very good tumor board, and thank you very much to those presenting. I hope you feel satisfied. And we will try to, Georgia, we will try to show your video at the next tumor board, okay? So thank you very much. We have to download the software on our end to show the video properly. We couldn't do it today. Thank you very much, everybody.
No problem. Thank you.